latest in screening and treatment for lung cancer. So I'm going to start with some introductory remarks, and then I'll introduce the speakers in turn. Tonight we have Dr. Blasberg, Chiang, Mase, and McGibbon. So Renee, if I may have the slides, please. So welcome. I'm glad to see so many people on tonight. I wish we could be in a lovely venue in Greenwich tonight. I think we all do. But that will happen again soon. From what I hear from our experts at Yale Medicine just this morning, people are quite optimistic about the vaccines, and hopefully we'll have plenty of them to Connecticut quite soon. In the meantime, of course, we have to be very careful, over the next months. Well, I want to talk a little bit about lung cancer research at Yale, just give a little introduction. So on the next slide, these are my disclosures. Next slide. Well, lung cancer is a major disease worldwide, and it's the reason we're here tonight to talk about some of the latest advances. It's the leading cause of cancer death in most countries, with over 2 million new cases worldwide. And 18% of cancer deaths are from lung cancer. In the US, for lung cancer, we have about 228,000 new cases a year, with 135,000 deaths. Most of lung cancer is non-small cell lung cancer. About 84% of it is. The other 15% is small cell. If you look at the pie chart on the left, you can see lung cancer is pretty much the biggest piece of the pie. This is new cases. Now, breast cancer, we screen for breast cancer. We screen for lung cancer too, as you'll learn tonight, but we screen more for breast cancer. Colorectal cancer, of course, we screen for as well. And you can see those are big pieces of the pie as well. But lung cancer certainly is a major enemy. And we'll talk tonight about some new treatments. Next slide. Well, the good news is we are making progress, and I'm old enough to tell you that we definitely are, because I've seen this over 25 plus years working in the field. If you look back, men on the top and women on the bottom, the red line is lung cancer, and you can see the number of people who succumb to this disease. Look how it peaked around 1990 for men. Why? Because that's about 20 years or 25 years after all the ads and efforts to get people to smoke. And, that's probably why, lung cancer really hit its peak, but it's coming down. And then if you look at women, you see the peak for women occurred a little bit later. Why? Because women started to smoke after men, but still you can see that peak's coming down as well. And the mortality rate has declined by 51% since 1990 for men, 26% since 2002 in women, due to reductions in smoking. And we're continuing, by the way, to work on that, certainly in the Connecticut area, and especially in the New Haven area proper. Many people, 18% or so, still smoke, higher than the national average. But if you look at the chart on the right, the table on the right, males and females, you can see the incidence is coming down, minus 2.6, but the mortality is coming down even more, minus 4.3%. And then if you look at women, the incidence is coming down, minus 1.2, but the mortality is coming down even more, minus 3.1. So what does this mean? I think it means some of our treatments are having an effect. Our immunotherapies, our targeted therapies. Let me show you some examples. Next slide. Now, back 20 years ago, maybe a little longer, this is what it looked like if you had lung cancer. The median, and this is for advanced disease, when your cancer had already spread from your lungs, you can see that you only survived, at 1 year, only a third of the people would survive this disease. It's much better now. The median was 7.9. It was clear, if you click again, Renee, that something new was needed. So on the next slide, you can see that we developed new treatments, and these are miracle treatments. This is gefitinib. This is a drug that targets epidermal growth factor, which actually is a mutation that occurs in patients who have never smoked or smoked very little. And you can see this is actually work that I did with Dr. LaRusso, who leads our phase 1 group at Yale. We published this in 2002. You can see the patient on the left. It's actually, they're both the same patient. Within 1 week of taking this oral drug, gefitinib, you can see the amazing response. You can see the lung has cleared up. On the next slide, that led to a whole new era of lung cancer therapy, what we call targeted therapy. The fact that we could target the epidermal growth factor receptor, shown on the left, with drugs in patients with lung cancer, as shown on the right. Cicely, the woman in that picture, spent 9 years on gefitinib with metastatic disease. Remember, the same disease I mentioned would only have about a third chance of even lasting 1 year with standard therapy. And this was written about in the Wall Street Journal by Tara Parker Pope. I think she now writes for the New York Times, that you could live with lung cancer with these new drugs. On the next slide. And then we developed newer drugs, because people become resistant to these drugs. And this is just showing a drug called osimertinib, the next generation oral agent for this type of lung cancer. And what you see with those lines below the -20, -40, those are all patients whose tumors shrank when they took this new drug. So the next slide. Next slide. And these are data just from the New England Journal of Medicine about 3 weeks ago, led out of Yale. You can see these are patients who had lung cancer and had surgery, but they had this mutation in this epidermal growth factor receptor gene. And on the left, you can see two curves. The blue curve on the right are patients who got this drug after their surgery, and the orange or yellow curve below are those who didn't. And you can see the big difference, actually a 72%, an 82% improvement. And then if you look at the right, you can see that in the brain, the solid blue line are patients who got the osimertinib, the new drug, versus those in yellow who didn't. You can see again a big improvement in outcome, actually 82%. So new therapies are coming. There's really a lot of hope in this disease. 1 or 2 more slides. Next slide, Renee. So we have at Yale much research going on. Most, if not all, the investigators talking tonight are involved in this. We work with our surgeons, our pulmonologists, our radiation oncologists, medical oncologists, and we're trying to target lung cancer with a big grant from the National Cancer Institute called a Specialized Program of Research Excellence. And you can see some of the ways we're targeting lung cancer by targeting immunotherapy on the left, epidermal growth factor resistance on the right, smoking cessation on the very bottom. Next slide. We have a team. Here's the current team and some of our leaders. I won't go through this for the sake of time, but Yale Cancer Center, Smilow Cancer Hospital is committed at all of its sites to providing the most up-to-date treatments, and these treatments are developed in the lab, bringing them close to the clinic, targeting immunotherapy, targeting growth factor abnormalities like I just showed you, and trying to treat cancer in the most updated way. On the next slide, this is the team. This is the phase 1 team. It's led by Pat LaRusso. She's in the blue shirt toward the right of the picture, about third from the right. And these are some of our investigators and staff. It really takes a team of investigators, of clinicians, of nurses, social workers, of coordinators to make these trials happen. And then on the next slide, I think this is about the end. Now I get to have the fun part of the evening and introduce the panel. So there's so much progress in this disease. What we've tried to do is put together a group of physicians tonight who will tell you about some of the latest advances, mostly dealing with early stage lung cancer. And we have 4 doctors tonight, and the first is Justin Blasberg. Dr. Blasberg is the Associate Professor of Surgery and Director of Robotic Thoracic Surgery at the Yale School of Medicine. He earned his medical degree from the Albert Einstein College of Medicine and completed his cardiothoracic training at the Massachusetts General Hospital. Dr. Blasberg's practice includes minimally invasive and open management for diseases of the esophagus, lung, mediastinum, chest wall, thoracic outlet, and diaphragm. He has a particular interest in benign and malignant disease of the trachea and performs the majority of his surgeries, when possible, in a minimally invasive fashion. If we could put up Justin's slide, we'll see the title of his talk. Welcome, Justin.
Thank you.
And,
I wish my mom was listening. That was so nice.
yeah, you can say, don't stop.
I'm going to share my screen because my slides have videos. Okay. Let me just make sure this works. Okay, I have to grant access. Okay, I actually have to log right back on. I'm sorry. I'll be right back. 1 second.
In the meantime, Anne, why don't you introduce yourself and tell us a little bit about the 15 plus sites around Connecticut where we have Smilow Cancer Care.
Sure. My name is Anne Chiang. I'm a medical oncologist, treat lung cancer, and I also have an administrative role as Chief Network Officer. So we have Smilow Care Centers throughout Connecticut, 15 different centers. Smilow Greenwich is one of ours. And it's very exciting. I see on the panelists, and the attendees, I see several of my patients, so hello. But we have a great program for you tonight.
So now we're going to hear from Justin about robotic surgery options for lung cancer.
Can you guys see my slides? Okay. You can see my slides?
Yes, very well.
Great. I feel a little bit like Frank right now. Sorry, trying to make this work. I know I got a chuckle out of Vinny. Tonight I wanted to talk about robotic surgery, which has become a big part of my clinical practice. And I think it represents a huge step forward in terms of how we manage lung cancer. In terms of disclosures, I am a proctor for Intuitive Surgical, which is the company that makes the robots that we use in the operating room. We're talking a lot about lung cancer tonight. When we think about the optimal management of early stage lung cancer, which includes smaller tumors and localized disease, we know from outcomes data that surgery is associated with the best chance of 5-year survival and the lowest risk of disease coming back over the 5 years following surgery. We also have other tools in our toolbox for these early stage patients that cannot tolerate surgery, like radiation therapy or ablation, and we'll hear a little bit more about that later. And these are really great treatment options for patients that we use all the time and are associated with success. I'm going to talk a little bit about the evolution of our surgical field because I think it's interesting for people to know how we do these procedures safely and effectively. For early stage lung cancer resection, our traditional approach back in the day was to make a fairly sizable incision, to divide some muscles in the chest wall, to spread the ribs with retractors so that we could access the lungs with our hands and actually perform these resections under direct vision. To the right on my screen is a scene from one of my favorite shows on Netflix, The Crown, and where King George VI actually underwent this kind of surgery and a pneumonectomy inside of Buckingham Palace in 1951. So these incisions can be uncomfortable, but that discomfort can be managed pretty well with pain medications. Patients need to stay in the hospital for some period of time, usually a few days, sometimes upwards of a week. And it does take time for patients to return to their normal activities of daily living, sometimes around 4 to 6 weeks. Starting around 25 years or so ago, we took a big step forward in a minimally invasive lung surgery with the development of miniaturized cameras and instruments that work through keyhole incisions, which led to the adoption of video-assisted thoracoscopic surgery. Or VAT surgery, as it is known, has magnified optics. The vision is 2D. The surgical instruments can perform some complex functions, and lung resection surgery can be performed through these small incisions to remove an abnormality of interest. At Yale, we have expert VAT surgeons who perform these procedures almost every single day of the week across our network. This operation is safe, it's reliable, and we train our residents how to do these cases with proficiency. We've also been very successful with our VATS, lung, and esophageal programs, and this has been our standard approach for many years now, allowing us to get patients out of the hospital faster, usually around 3 to 4 days. These patients require less pain medication than open incisions, and the return to their baseline is much shorter compared to open surgery. So that brings us to robotic surgery, which is one of the things I'm most interested in. And at least in lung cancer, it represents an opportunity to bridge the gap between open and video-assisted surgery by combining the technical advantages of open surgery, but with the patient-specific benefits of minimally invasive video-assisted surgery. So in this type of technique, a surgeon sits at a console. They control robotic instruments inserted through similar keyhole incisions or ports that we use in video-assisted surgery. But these instruments actually attach to robotic controller arms. The instrument tips can move with multiple degrees of freedom. They can perform complex functions, and essentially they perform the same technical functions as if my own hands were doing the operation. I move these instruments around using hand controls, as you can see here, that allow motion, that allow for the exact motion of my hand, and they let us do things like dissect important structures in and around the lung. These motions are basically the same as if I were performing this procedure at the bedside open, except that I'm viewing structures at 10 times magnification in three-dimensional, with a three-dimensional camera. And this allows me to divide blood vessels, the airway, or remove lymph nodes using robotic energy devices with increased precision. The value of robotics is that it simulates open surgery, but with a huge technical advantage, not just the 3D visualization or those articulating instruments, but the size of the incisions and the incision placement can be performed in areas where there's less discomfort for patients, that is. Simulating open surgery, these instruments allow us to be extremely thorough with our dissection and to keep patients safe, especially during the most complex components of the case. There are other patient-specific benefits like reduced incisional discomfort, shorter length of stay, reduced blood loss, and with a significant amount of experience, we've been able to successfully integrate this platform into at a system level to reduce our length of stay, to improve our short-term outcomes, and most importantly, to get patients back to their standard quality of life and their activities of daily living. As this technology improves, actually the platform is getting smaller. This is a video of a single port robot that we now use at Yale, and we're one of the first sites in the country to have access to this technology. Instead of 4 separate keyhole incisions for 4 instruments, the platform allows for 1 port that contains all instruments. So for abdominal surgeons, they can hide this port in your belly button and remove your gallbladder without compromising on safety or quality. And we're really excited about these kinds of opportunities, mostly because we think it'll help patients recover faster. And clearly, this is the direction where small incision is going. Small incision surgery is going, especially for our lung patients. We're also excited about about the opportunity to use robotics to help biopsy or mark tumors that we can easily remove in the operating room. Here's an example of a robotic system that uses a flexible catheter to navigate through a patient's airway. We now have the ability to perform these kinds of procedures where computer software identifies a nodule within the lung and the pathway to access that nodule. And then using a control unit, an operator can drive out a robotic catheter into the lung, allowing us to biopsy a nodule or even inject it with a specific kind of dye that we can see in the operating room. As a result, we're really proud of our surgical results. We're able to perform minimally invasive lung resection in 90 to 95% of our early stage lung cancer patients. That's both VATS and robotic surgery. Our average length of stay is well ahead of our national averages and our academic peers. Our complication risk after surgery is very low, and our surgical mortality is also very, very low. As important, the lion's share of our patients are discharged home rather than needing a transitionary period in either a rehab center or subacute nursing facility. And now that we're bringing all of these minimally invasive technologies to the hospitals across our system, including Greenwich and Bridgeport, there's a great opportunity to offer more patients these options for early stage lung cancer and other thoracic cancers. And with that, I'd be happy to take any questions.
Thank you, Justin. That's phenomenal. We're beginning to get some questions. One person on the line has asked, can you do a pleurodesis using the robotic, the RATS procedure?
So a pleurodesis is a sticky procedure where we usually either scratch up the surface of the chest wall or put in medications like a baby powder, talc powder, or an antibiotic like doxycycline to cause the lung to stick to the chest wall to prevent it from collapsing. A procedure that's similar to that is actually referred to as a pleurectomy, where we strip the lining of the chest wall, and that allows for the same effect, actually an even better effect. And so a robotic pleurectomy is a commonly performed procedure by our group, is very effective, and it's great with the robot because there's a little bit less bleeding, and I think it's a little bit more thorough.
Great, thanks. Please put your questions in the chat. I have a few others here. Someone's asking, Justin, were you good at video games when you were a child?
So I did play a lot of video games as a child, and I think that does help with hand-eye coordination, but my parents also forced me to play the cello. So I think that probably helped. So
we should have our kids both do the music lessons and they can play a little bit, at the arcade. No, but seriously, when you went, have you always trained in robotic surgery, or did you have to make a transition at some point in your career? And what about surgeons more advanced in their career? Was it hard for them to learn these techniques?
So this is the interesting part about robotics. I actually trained at MGH, where there was no robotic surgery and no VAT surgery. It was essentially all open surgery, even in 2011 to 13 when I was there, not too long ago. I learned VAT surgery in at my first job, and I learned robotic surgery actually here at Yale when I started with Tony Kim. The value of robotics is that because it simulates open surgery, it's actually much easier for a traditional open surgeon to learn rather than VATS. The learning curve with VATS is much higher, much steeper. So it is an interesting phenomenon that minimally invasive surgery is better for patients and more open surgeons to transition to minimally invasive surgery, increasing the overall performance of minimally invasive surgery, combining VATS and robotics. And so it is a more natural platform for open surgeons, and that was the case for me as well.
Right. We have another question. There are a lot of disparities in healthcare. A lot of places don't have surgeons like you and Vinny and others. Can this be done remotely? So could you control an operation from Cedar Street, someplace else in the country where there might be fewer physicians that have that expertise?
So the answer is technically yes, although I don't believe anyone actually does that. I think there was a landmark case years ago where they remotely operated on a patient across an ocean between countries. But I don't believe that there's any site that's actually physically doing surgery remotely, maybe in the military, and Vinny could speak to that, but I don't believe in any other capacity. It's not what we typically do, but there are so many robotic surgeons across the country now that it doesn't take much to find somebody within your region who can provide something like this.
Great. Well, that was fantastic. Maybe not now with the COVID virus raging, but someday I'd like to join you in the operating room and see how that works. And
you're welcome to.
I'm not sure I could even tie a knot, but maybe the robot could help me do it.
Tie it for you. Yeah.
Okay. Well, thank you, Justin. That was fantastic. Okay, moving on. And I see some questions in the chat, but I'm going to wait till they're relevant to the topic of the talk. And some of them will be relevant now for Anh Chiang. Dr. Chiang is Associate Professor of Medicine in Medical Oncology and Chief Network Officer and Deputy Chief Medical Officer for the Smilow Cancer Network. She specializes in thoracic oncology with a background in translational research and metastases, as well as extensive experience in clinical practice in both academic and community settings. Dr. Chiang's research interests focus on development of clinical trials and translational studies to test novel agents and combinations with immune checkpoint inhibitors for both small cell and non-small cell lung cancers. She received her medical degree from Cornell University Medical College, my alma mater actually, and her PhD from Harvard. And it's wonderful to have you here talking about some of the new medical oncology treatments for lung cancer. Anne.
Thank you. It's my pleasure, and I'm going to share my slides. I wanted to talk about the advances in treatment of lung cancer from targeted therapy to immunotherapy. And Roy, you did mention a little bit of this, so thank you very much. Let's see. These are my disclosures. I'm going to talk about non-small cell targetable mutations. I'm going to talk about non-small cell patients that incorporate advances that incorporate combination immunotherapy and chemotherapy. I'm going to talk a little bit about side effects associated with immunotherapy, and then end with treatment of patients with small cell. So there's a lot to cover, and I will do my best to go through this relatively quickly. We'll see how we do with time. I'm supposed to finish in 15 minutes. So as Dr. Herbst said, lung cancer comes primarily in two forms: non-small cell and then small cell, which is around 15%. And of the non-small cell, most of it is adenocarcinoma, 35 to 40%, squamous cell carcinoma, and then large cell. And those are histologies, and that's actually shown in this slide. So underneath the microscope, small cell looks like little blue small cells, as named. Adenocarcinoma, adeno means Greek, and gland in Greek. And so it describes the formation of these little glands. Squamous cell often has what's called keratin pearls, and then that's large cell, which is sort of the other category. Dr. Herbst mentioned the mortality and incidence of lung cancer is coming down. And this is a paper from the New England Journal of Medicine that came out this year that shows this. Very exciting for on the left, men, and on the right, women, both in blue, the incidence, so how often it occurs, and then the mortality in red. So that's both going down for men and women for non-small cell and for small cell, and in part due to many of the advances that I'm going to talk about tonight. So let's first talk about this concept of personalized medicine in lung adenocarcinoma. So back in 2004, we really talked about we would do profiling or look for mutations in the tumor tissue. And we were really looking for only two things, EGFR and KRAS, that were described at the time. And now in 2014 and even more so now, we are looking for a dozen targets that actually have drugs that can be used against them. So I'm going to start with specifically EGFR therapy, that's epidermal growth factor receptor. And there are mutations in this particular gene that basically are most common in never smokers, females, Asians, and adenocarcinomas. And if you have these mutations, then you can take an oral EGFR inhibitor medication, oral pill, and you can have very good response rates. And here's an example of a patient who had a lung lesion in that's here in 2016, and you can see some shrinkage in the next panel over there. And this is another example of a patient. This is a CAT scan, and at day 0, before they started taking that medication, they had a lot of cancer. These are these lesions here, and you can see that really cleared up 4 months later. But then over time, you had some regrowth. And this is this concept of, you know, the medication works, but it doesn't work forever. And there are some cells that can develop resistance. And one of the ways that we've been able to characterize this, many researchers, is to then look at these cells that develop and look for mutations there. And so through that kind of analysis, researchers were able to find that sometimes it was a secondary mutation that then caused difficulty for the drug to bind to its target, or sometimes it was another pathway that was activated. Or rarely, maybe 5% of the time, the cancer had actually changed and transformed into small cell. So this idea of precision or personalized medicine is shown in this graph here. And basically, before we used to think that lung cancer was one diagnosis and everybody got the same prescription, which was chemotherapy. And so with the advent of looking at particular mutations, then we could say, okay, if you were these folks in green who had an EGFR mutation, you can be treated with an EGFR drug. If you have the RET mutation, you can be treated with a RET targeted drug. And if you had a different mutation, you could be treated with, say, MET inhibitor, and everybody else would get a different treatment, the treatment D in that category. So this slide actually is the summary of all of these agents that really have been approved, developed and approved and available for patients in the past decade. And this is really tremendous work by many people, and it represents really the realization of that idea of personalized medicine. So depending on the mutation that you have, there are multiple drugs available. The ones in bold are the ones that are recommended, but all of them are developed. Even for the RAS mutation, which has been one that has been very, very difficult to target and very often characterize smokers, folks who have an extensive smoking history, their mutation. We do have clinical trials now that are very, very promising, being able to target those RAS mutations. So in conclusion, for the targeted therapy, you need to know the target, the mutation status, in order to use the therapy. If you have disease that, and I saw there was a question on this, if it's late stage or metastatic, in other words, spread to different organs, you can use these agents, but it's not curative. It can prevent the disease from growing and shrink it for a long time, but you have to be able to target, use biopsies and figure out what mechanisms of acquired resistance are occurring in order to continue to treat that. And certainly standard chemo alone and in combination with immunotherapy is still an effective tool for these patients as well. So now I'm going to shift, well, actually here, you can see the advances that have occurred, in the past decades. And all of these yellow and orange and light purple are what I just highlighted, those changes, those discoveries in the area of mutations and drugs that target those mutations. The light blue over here, and this is Dr. Herbst's paper in Nature, you can see that, point to advances in immunotherapy, and that's what I'm going to talk about now. So just to go back to how immunotherapy works, think of cancer cells. They develop many mutations that make them appear foreign to the immune system. The T cells, that's part of your immune system, can actually recognize, attack, and kill these foreign cancer cells. However, cancer cells are really tricky, and they express PD-L1, which is a protein, and that helps them become evade the immune attack, and so that the immune system can't see them. And so what happens is that PD-L1 basically dampens or decreases the anti-tumor response. So that's why these therapies, immunotherapies that target PD-1, which is on the T cell, and PD-L1, which is on the tumor cell, are effective. So basically these the drugs or antibodies here, anti-PD-1, anti-PD-L1, will prevent the interactions between the T cell and the tumor cell to basically allow the immune system to wake up and recognize those cancer cells as being foreign and try to get rid of them. And the advantage of immunotherapy over chemo is that it's very specific for that cancer cell, as opposed to chemo that sort of attacks all cells that are dividing quickly. There is a memory component, so a durable response, because the immune system can remember, and then there's adaptability. So I'm going to just talk about a patient of mine, just to sort of illustrate some of these points. So this is a patient that I saw for the first time in 2014 and had lots of pain and shortness of breath and had neck masses, as well as a PET scan that showed disease in the left lower lung and lymph nodes. So that's the left lower lung, and that's lymph nodes on the PET scan. And the brain MRI had 3 tiny lesions. And so the biopsy of the cervical lymph node showed lung cancer, no mutations detected, so we couldn't use that targeted therapy. And that patient went on a clinical trial for a drug called pembrolizumab or Keytruda. You might have seen that, the commercials for that. And started 2014, and in February had scans that showed a really terrific response in the brain and body. And This is just to show that in 2016, so this is the advantage of a clinical trial, is you can really have some of those cutting edge therapies before they get approved by the FDA. And in this case, it was really 2 years later after the patients started that the FDA was able to approve this drug Keytruda for non-small cell. So he did actually quite well until March of 2015, then had very bad diarrhea, was treated for steroids, and this was a toxicity, so this was a side effect. He was on steroids for a while and tapered off, and then had symptoms, and then was finally treated with a different drug that really resolved the diarrhea. And most exciting, I just saw him last month, 6 years after his original diagnosis, and he has no evidence of active disease in his brain or his body. So this is really, I think, a happy ending that highlights the importance of clinical trials and the excitement around immunotherapy. This is an article that Dr. Herbst and I wrote to basically show the different options now available for patients with squamous cell and non-squamous cell lung cancer. And in addition to those, this we wrote in about a year ago, in the past year, we've had an additional 3 approvals for combination immunotherapy, immunotherapy with 2 cycles of chemo, and then another agent immunotherapy for high PD-L1 expressing tumors. So really a rapidly and very exciting field. This slide is just to show some of those trials, which were phase 3 trials. And what I've highlighted is the impact on survival. So not that you have to know these numbers, but this, for example, this trial, which shows the results of combination chemo and immunotherapy, which has become our standard of care, shows a 50% reduction in the risk of death. So really significant advances for lung cancer. One of the questions we have is chemotherapy even necessary anymore? And I think that this is an important question, that a big trial, this is a national trial that I chair with Haas Borgai, and we have this trial will have 880 patients, and we have about, we're a little over a quarter of the way through accruing patients to this trial. And what we're testing is whether or not you can start with immunotherapy alone and then go to chemo if you happen to progress, or if you can add chemo if you happen to progress, and then this is our control. So very exciting clinical trial. And this is open in Greenwich. Dr. Lee and the other medical oncologists there can put patients on this trial as well, can participate. You can participate. This is just to show the spectrum of toxicities, is that you can, when you're ramping up the immune system to recognize the cancer, you can sometimes recognize your normal tissue as well. And the way that this is treated is usually with steroids, and I'm not going to go through this slide, but you can be quite effective in that way. So the conclusions here for immunotherapy is that we have these new PD-1 and PD-L1 inhibitors that are active. Very excited about the durability of response, and the toxicity is manageable. It happens, but it is manageable. It requires very early intervention, and we're trying to study this area, biomarkers, to understand who can respond, and that there are lots of drugs that are approved for non-small cell lung cancer. And finally, just a few slides on small cell, which is also a passion of mine. This is a little bit different than non-small cell. These cancers, unfortunately, grow very quickly, and they can metastasize and spread. But they're also exquisitely sensitive to both chemotherapy and radiation. This is the past decade of advances, and it's been pretty sparse over the past 30 years. However, again, the landscape is really changing now, and there have been some very recent advances, both in immunotherapy and understanding small cell biology. This is just to show that, again, small cell, we're starting to tease out what are the molecular drivers and understanding that it's not just one flavor, that there are different types that we can perhaps approach differently. And the key points here, the key updates, 2 new FDA approvals for immunotherapy plus chemo in the front line. That means when you're just diagnosed. 1 new second-line FDA approval for a drug called lurbinectedin, which is a chemo. And then just highlighting the need for understanding biomarkers and other options for patients who might progress in immunotherapy. And I think my last slide is, again, this is a clinical trial that a fellow had helped me to write, and have open now. This is a clinical trial open, also available in Greenwich, where we're doing a biopsy pre-treatment, and then at week 4 for patients treated with combination immunotherapy. And we're really trying to understand with these biopsies, how can we see what changes in the tumor microenvironment are going to tell us who's going to respond or not. And that way we can really understand how the disease works and how to attack it. And this is just a moment of peace in this time of COVID. And again, hoping that all of you are safe and wishing you the best. So that's it, Roy.
Thanks, Anne. That was wonderful. We have a lot of questions here. So someone's asking about EGFR and immunotherapy. Why not use them both together, the EGFR drugs and the immunotherapy drugs?
Wow, that's a great question. And there are clinical trials that are looking at both of them. You have to be tricky though, because again, when you're combining 2 drugs, you have to be careful that there aren't specific toxicities that go hand in hand together. So that is right now, it's not our standard therapy because those trials haven't resulted out yet, but we're learning more and more. Right now, we are using them as we're in there for the marathon. So we're trying to develop as many tools in our kits to use. And so we use the targeted therapy separate from the immunotherapy, but we're testing them together to see if we can get better and more effective tools.
Great, thanks, Anne. Someone's asking about whether you use liquid biopsy, AKA blood, in your practice for molecular testing.
Absolutely. I think that's one of the most exciting things. And Roy, there was a New York lung cancer conference recently when several cases were shown, and basically now you can use the liquid biopsy up front, and then you can use it along the line when you're developing resistance. And I think it's a really great tool that we're going to see more and more of.
Okay, a specific question. Someone says that the quality of drugs has improved. I was on afatinib for 4 years and documented 14 different side effects with its use. I'm now on Targresso and have 1 mild side effect. So, Anne, thoughts?
Yeah, you know, afatinib is a really hard drug to take. So, you know, kudos to you. Osimertinib, which is a 3rd generation drug, much more effective in the brain. It has really good CNS penetration, and it's much easier to tolerate. So good for you. That's wonderful news.
Are there some specific situations where we still might use afatinib?
There are. And so this is how, again, we can use the idea of tools. We can sometimes recycle these tools. And if you think about, you know, that idea of acquiring resistance, you may develop and you biopsy at a different point in time. You might have been really effective in controlling one particular form of or clone of the disease, but it may have changed, and actually you might be able to go back to afatinib, which is what I did with one of my patients relatively recently.
Great. And the last question I have here is about anti-angiogenesis, the importance of those drugs, and are they still used a great deal?
Anti-angiogenesis that whole class of drugs is really important. And I describe it usually to my patients, you know, when a tumor initially grows, it uses the blood vessels that are there, but as it really is, you know, developing, it builds its own blood vessels. And so these drugs help to choke off the growth of new tumor-associated blood vessels. And we're finding that you can combine those with chemo and with immunotherapy together. In one case, there are also some clinical trials testing those drugs with the targeted drugs as well.
Excellent. Any more questions? I don't see any. Thanks, Anne. Really appreciate that talk and all you do for the clinical trials and for our network.
Thanks, Roy.
So now I'm really excited also about the next talk, because screening for lung cancer is so important. And I'll tell you, I think it's underutilized. So we have to figure out how to get more people screened, because finding these cancers early, as you're about to see, can make a big difference. So for that, we're very fortunate to have Vinny Mase. Dr. Mase is an assistant professor of surgery, thoracic, and he cares for a patient at Smilow's main campus and at the Smilow Cancer Hospital Care Center in Trumbull. He received his medical degree from the University of Vermont and completed his fellowship in thoracic surgery at Brigham and Women's Hospital, another one of my alma maters. Dr. Mase used the latest technologies for the surgical treatment of lung cancer, chest wall deformities, and other problems that affect the chest, including the diaphragm and esophagus. He is skilled in performing minimally invasive thoracic surgery and has an interest in quality outcomes research. So this is great. I'd love to see tons of questions from this, because who do we screen? When do we screen? Why do we screen? So Vinny, the floor is yours.
Great, thank you. Can everyone see my slides?
Yes.
Great. I think for the people that are on, we started with about 55 and now we have 57. So for those of you that are here tonight with the Smilow family, I just want to thank you for, sticking with us. It's a great crowd. I actually see some of my patients and actually some of the family members of some of my patients in the room there. So thank you very much for joining us tonight. And I just want to let you know, I mean, after this session, you're all in a way a subject matter expert when it comes to the advances in lung cancer and lung cancer screening. So, go out and educate your family and friends about what you learned today. Certainly encourage you to do that. Basically, what I'm going to talk about today is just some local health statistics specific to Connecticut, the efficacy of lung cancer screening, and really kind of what I thought would be important to you or questions you may have that come down to some nuts and bolts, like what is a chest X-ray and how do I look at it, or what's the difference between that and a chest CT. And basically, Dr. Herbst talked a little bit about his pie chart early on in his talk that was for the significance of lung cancer for the globe. This is the Connecticut cancer statistics for 2010, and what you can see is that lung and bronchus cancers account. It's the third leading newly diagnosed cancer, but it's the most, when you look over at cancer deaths back in 2010, it's the most lethal, accounting for almost 25% of death from cancer in 2010 in the state of Connecticut. And there's some reasons for that we know about. It's a silent disease. It's certainly found in more advanced stages, and up until recently, we haven't had an effective screening tool like there is for breast cancer, like there is for prostate cancer, that helps to identify patients at a younger age. And certainly Dr. Chiang highlighted some of the many novel therapies that help to combat the lethality of lung cancer, but certainly what we're trying to do now going forward is trying to identify it in those earlier stages. And now we have the data. I'm not going to go into the weeds with regards to the randomized control trials. This pie chart is just to impress upon you the size, particularly of one of the studies, the National Lung Cancer Trial. Over 53,000 patients were enrolled in that trial to show that there was a benefit with regards to using low-dose chest CT to detect lung cancer in earlier stage. And there was a 20% mortality reduction using low-dose chest CT. Over in Europe, there was another trial that came out just recently. Again, more than 15,000 patients that were enrolled that demonstrated a similar mortality benefit. And it's certainly something that we're at Smilow are working across the network to have available and is available. And compared to other known health screening screening exams for cancer, low dose chest CT, the number needed to screen to prevent one death is about 320. When you look at mammography for breast cancer, the number needed to screen to prevent one death is anywhere between 780 and 2,000 when you look at the literature. And colon cancer screening, again, mammography and colonoscopy are certainly two screening tests you're familiar with and may have even had. The number needed to screen to prevent one death is about 1,250. So low dose chest CT certainly has been shown to be effective as a screening modality for lung cancer. Now, what I've talked about just now is just a pie chart, just some large randomized control trials, and a term numbers needed to screen. What I really think that sometimes what happens is that the content delivered is important, but how we deliver it as doctors is also important so that you can understand it and you know how it applies to you and make decisions. And I think the biggest thing with regards to lung cancer risk is that I want to drive home today is that there's two factors that impact it. One, it's age, and two, it's smoking status. If you just kind of take a look, I don't know if you can see my arrow here, but as your pack year, if you look at if you're a smoker, as your number of pack years increases, and as your age increases, your 6-year lung cancer risk dramatically increases. And really, it's the smoking status that we work to target with our patients. Now, what's a chest X-ray versus a CAT scan? I know sometimes patients come in and they think they had a CAT scan and they might have had a chest X-ray or vice versa. To the left is basically what a chest X-ray looks like. It's pointed at you. You get essentially you use shadows to try and make distinctions with regards to the lung or the structures in the chest. On the right, you can see the way the CAT scan is arrayed is it's like you're laying on your back, you're being sliced essentially like a loaf of bread, and we're looking at you from your feet. So that over here where you see my arrow is your right lung, over here is your left lung. And the way the radiation beams are essentially from all different directions so that you get, as you can appreciate, you get a lot more detail with regards to chest anatomy and organs in the chest. Just some basics for how to read a chest X-ray. You can certainly see here that the chest X-ray gives us a lot of information. You can see that we can see your airway, we can see your heart, we can see the structures that come off the heart. We can also certainly assess the bone structures around your chest wall. We can see your spine as well as your upper airway, and we can even see a portion of your abdomen. So it certainly provides helpful information, but it's not sensitive, and it certainly isn't a screening test. In the past, early on, when we want to talk about advances in lung cancer screening in the 60s and 70s, they looked at over 180,000 patients and over 20 years of follow-up for chest X-ray as a way to detect nodules, and it turned out not to be beneficial. And I think the reason why that's important, or as a take-home message, is because if you went to the ER and maybe got a chest X-ray because you had a cold, and you may be someone who's at risk for lung cancer, that certainly isn't sufficient in today's day and age as a screening modality for lung cancer. And this is an example of an X-ray where you do see here there's a lesion that was picked up, fortunately for this patient. But the take-home message here is the chest X-ray is not a screening test. And I guess just, how big is 2 centimeters? The metric system sometimes comes up every once in a while. And a 2 centimeter lesion turns out to be about the size of a penny. Penny is about 2 centimeters. A little Cheerio is about 1 millimeter. The pencil eraser is about 5 millimeters, and a golf ball sized lesion turns out to be about 4 centimeters, just as a reference for some of you that can go onto my chart and read some of your imaging. Now, a chest CT, as you can see, is a lot more detailed. We can certainly see the vessels in a little bit more detailed structure. We can see the lung certainly in a lot more detail, as well as the muscles of the chest wall, the esophagus, a lot more detail to be able to detect, and what the studies have shown, to detect lung cancer at an earlier stage and provide a benefit to you. This is just to show that chest CT is an effective screening test, and there's a lung nodule here that ultimately wound up being resected. So who's eligible for lung cancer screening at Smilow? Basically, we target high-risk patients. Those are the ones that benefit the most. It's adults. If you're between the ages of 55 and 80, if you have a third pack year smoking history, whether you're a current smoker or if you've quit within the last 15 years, individuals who typically are asymptomatic and certainly could handle treatment with regards to whether it's surgery or oncologic treatment. Now, what are the risks? And these are some of the things that sometimes come up is, when you get a screening study such as a CAT scan, it doesn't just look at your lungs, it looks at everything in your chest from your neck down to your abdomen, to your belly. And one of the things that comes up is we can sometimes have a false positive. That's identifying a lesion that may be there that's not a cancer. People often ask about what the radiation harm is, and I'm going to talk about that in the next slide. There's a much smaller, less than 1% risk of biopsy or surgery with regards to if you identify a lesion that needs to be treated. And then there are incidental findings. And what that means, since you're scanning from the neck down through the entire chest, we look at your thyroid gland, we look at your esophagus, we look at your airway, your chest wall, and there are lesions that can sometimes be identified, such as a thyroid nodule. What is the radiation risk? The radiation exposure from a low-dose chest CT is very low. A millisievert is how it's measured. It's less than 1. And just for comparison, the background radiation, if you live in New York City, is about 3 millisieverts. Essentially, the radiation exposure from a low-dose chest CT is equivalent to flying on an airplane from here to California and back. Very low risk. Now let's talk about the benefits versus the risk. And that's one of the things that those studies kind of work to identify. And I talked about earlier, the number needed to screen to prevent a death from lung cancer is 320. The number needed to harm, or the risk to the patients, to you, is dramatically higher. It's close to 4,000 patients that need to be screened to have a side effect or some sort of harm from the screening test. And just to drive home some of the main points, the eligibility criteria, and it may not be you, it may be someone you know. Adults 55 to 80, 30 pack year smoking history, a current smoker or quit in the past 15 years, no signs or symptoms of lung cancer. You can certainly expect, you can talk to your primary care doctor about it to see if you're eligible. If you are, you can certainly expect a visit reviewing the risks and benefits to kind of review some of the things we talked about today. And really the important thing is, particularly here at Smilow, one of the things we believe, it's not just a scan, it's really a team of experts, some on this panel who are involved in your care from the time you get that. Are there any questions?
Thanks, Vinny. That was wonderful. I'm sure there are some questions. I have one as we wait for them to roll in. And why wouldn't everyone eligible get screened? What's the barriers? What's keeping people from coming in and doing this more? Because the national numbers that I read say 5 to 10% of eligible people are screened, maybe lower.
Yeah, I think it's a great question, and the U.S. Services Preventative Task Force estimated that if everyone who was supposed to get screened got screened, I think in America it's about 3 million or 4 million people. There'd be about 128,000 people that could be saved from lung cancer if we were able to institute this effectively. And it's actually one of the reasons why, even as a surgeon, I've been interested in lung cancer screening, because it's about logistics. There's a fair amount of logistical issues that come in with regards to tracking the patients, managing some of the findings component. Those are some barriers that have prevented us from having as much compliance as there is with regards to either breast cancer or colon cancer from mammography or colonoscopy.
Right. What is ground glass? Someone asks. Why do you call it ground glass?
We call it, that's a great question. So I will share my screen again and see if I can go back to the picture. Can you guys see my screen again?
We can.
So if you take a look at this lesion is solid, which means it's filled with cells. A ground glass lesion means that it would be essentially fuzzy. It would be, it wouldn't be as filled with cells because it's kind of amorphous. It's partially filled with cells. It hasn't filled in yet. So a ground glass lesion, what we have found is either a precursor or early form of lung cancer, adenocarcinoma. That's what a ground glass lesion is. So that's a great question.
Yeah, we have so many more. 30 pack years, what does that mean? I guess, you're listening in the audience, can you define that a little bit better, Vinny?
Yeah, so a pack of cigarettes, from my understanding, has 20 cigarettes in it. I haven't bought a pack, but that's what my understanding is. It has about 20 cigarettes in it. So if you smoke a pack a day, that's, and you've been smoking a pack a day for 30 years, that makes you a 30 pack year smoker. There are some people who smoke less than that. They might smoke a half a pack a day. If you smoke a half a pack a day and you've been smoking for 30 years, that means you're a 15 pack year smoker. So a pack year is basically, the standard is a 30 pack year means you've been smoking a pack a day for 30 years.
And how exact are you on this? So if someone is worried about lung cancer, wants to be screened, I guess it's sort of hard to sort of know exactly what one smoked. You give them a little flexibility here?
Well, that's an interesting question. And that's actually one of the challenges for trying to institute, or one of the reasons nationally why there's a challenge with lung cancer screening to be implemented is the accuracy of that. What we have found is we try and, with regards to that high risk patient population that I put up here, 55 to 80 and that 30 pack year smoking history. What we have found across the country, that is, if you're a little bit more liberal with that. So let's say it's, you say, well, what if I just smoked a 10 pack year smoking history? Or what if I smoked smoked a cigarette when I was 8? Should I get screened? What we have found is when you do that, when you cast a wider net, when you talk about the risks versus benefits, the number needed to screen is dramatically higher. So to answer your question, Roy, is we try not to, at least for lung cancer screening, we try and stick with what the guidelines are.
Okay, I'm going to hit you with a lightning round here. A couple of risk factors. Do we screen or not? Radon gas. You got radon in the basement. Screening?
No screening yet for radon gas. There was another question early on if there's studies with regards to radon gas and risk of lung cancer. And actually, there have been some studies, and radon gas is a significant risk factor for lung cancer, but it doesn't fall in the category of something you'd screen for it.
What about smokers? Do we screen them?
Not today, not with regards to the technology that we have today.
Someone with family history of lung cancer, should their kids get screened?
Oh, that's a great question. You wouldn't fall in the criteria because you wouldn't be a high risk patient, but that's not typically someone that we screen.
Okay, we read a lot about AI now. The Teslas, sending these rockets to the moons automatically, are using AI right now to help with detecting what's a tumor, what's not, so that you can avoid doing surgery sometimes.
No, it's great. You talked about going to the moon. I just want to go back to Dr. Blasberg's question about the military and the robot. So the military's tried to, work to apply that, but one of the challenges is you got to get the robot into the area, and it turns out that it's easier to send somebody than send the robot right now. But the robot actually was interesting because NASA's been trying to use it because it'd be great to have that capability when you have people either on the moon or at the space station. But to answer your question about AI, there is some literature that's looking into using AI to identify these lesions, but it hasn't worked itself into lung cancer screening yet.
Yeah, I just ordered a medical oncologist robot so I can take tomorrow off. They're working on it. What about, seriously, when the biggest issue, I guess, here is you go in and it's benign, it's not like a breast cancer screening or a colon screening where the procedures, are done usually at the same time or very close to the same time, a little bit easier. You think that's a deterrent why people don't come in and be screened more?
I think it is. I think there's a system deterrent. I think there's a patient deterrent. And I think that is one of the challenges. Yeah, it's one of the things that we're as the network kind of works to figure out how to continue to grow. It's one of the things that we're trying to sort through.
Yeah, there are huge disparities, of course, in who gets screened and who doesn't. If you look along populations and the socioeconomic determinants of health, we're actually doing a lot of work right now to go out into the community with navigators to find people in the populations where smoking might even be at the highest levels. What are your thoughts on that? In Bridgeport, that must be a big issue.
Yeah, I think it actually is a big issue. And when we dialed down, I showed you the pie chart for Connecticut. We've actually in Bridgeport and Fairfield and Greenwich, we've dialed down to know what the smoking rate is by town. And there are navigators that are going around to local areas as an outreach to try and work to get people to be enrolled who are at risk. The smoking rate in Greenwich right now is 7%. In the state of Connecticut, it's 11%, and in Bridgeport, it's actually 21%. So to answer your question, Roy, we're down to that kind of detail with regards to outreach.
Incredible. Well, Vinny, that was an amazing talk. I learned a lot time. Thank you, and we'll hopefully have you again at some point in the future on this series. Okay, well, last but not least, the radiation oncologists are always in the basement, but we're really fortunate to have, talk about radiation oncology and lung cancer, Bruce McGibbon. Dr. McGibbon is an assistant professor of clinical therapeutic radiology and medical director of radiation oncology at Greenwich Hospital. He received his medical degree from UCLA School of Medicine, where he also completed his residency. Dr. McGibbon treats many forms of cancer, including breast, prostate, lung, rectal, head and neck, and primary metastatic brain cancers. His research interests include a focus on quality of life, improvements in short course radiation therapy using stereotactic techniques, which he'll explain to us. Bruce, so glad to have you here tonight. Thank you.
Thanks, Roy. Thanks for having me. Let me try to share my screen here. There we go. Start. All right. So just going to touch tonight on some of the advances in radiation therapy for lung cancer, especially in early stage. I'll talk a little bit about oligometastatic. Just a quick look, just for interest, we looked at the robot, which is really exciting, and I just want to show you an internal view of a radiation machine. So this is a schematic of a typical machine on the upper left, and the arrows, you can see these red arrows show that actually an electron gun is in the machine that shoots electrons down and accelerates them, which is why the machine is called a linear accelerator. They get spun around and then smacked into a tungsten target. And what comes out are X-rays, and those shine down at the patient. You look at the lower right here, the Varian is the name of the leading manufacturer of these machines in the world. And at Greenwich Hospital, for example, we have the TrueBeam, which is one of their state-of-the-art machines. You can see it has the kind of similar design idea. And people often ask, about safety and are they going to wear a lead blanket or how are they protected? And we don't have lead blankets and things like that in the room because they wouldn't really stop the X-rays that we're using because they're too high power. But what we have is something in the head of the machine called a multi-leaf collimator, which is about 3 inches thick. And so it's as if you have a 3-inch thick lead blanket protecting you up in the head of the machine. And this is what allows us to create all the shapes. So if I go back to this, you imagine the patient lying on that black tabletop there. We can manipulate the angle of the tabletop. We can go up and down. We can spin the machine around different directions, and we can change the shape of the beam. And so all those things allow us to create some fancy targeting of the radiation. Another thing which is a big advance for us, it's been around for some years now, but we keep refining how and when we use it, is called image-guided radiation therapy. And as we got more sophisticated with the shape of the beam, we have to be more and more careful that we are actually on target. Old style radiation, treat big fields, a whole pelvis or a whole breast or whatever it is, and you don't have to be so refined. But now we do. And so if we look at again on the lower right, this is more of a face-on view of the machine instead of from the side, and those little arms are sticking off to the side are actually imaging arms. And so we can spin the machine around the patient before treatment and get an image which looks very much like a CAT scan. So on the upper left, there's a split view here, where the upper left and lower right are from a real CAT scan done for radiation treatment planning, and the lower left and the upper right are from the cone beam CT. You can see that the image quality is just a little bit different, but really quite excellent. And the red circle there, or actually oval, is showing the tumor that we're targeting on that day. So this is the way we can set people up, have marks on the skin to get them quite close, but then we do the cone beam CT, and then we really dial it in. So you're talking about millimeter or sub-millimeter. The other thing we've done with the shaping of the beam and manipulating the position of the machine itself and the table itself is that we've gone from using what's called 3D conformal radiation, which I'm on the left, with intensity modulated radiation therapy on the right. And this we call the view a color wash. It's almost like a topographical map. And you can see on the right that the dose is more constrained. It's really targeted much more to the center of the chest. In this case, this is someone being treated for a tumor in the esophagus. But you can see you can see my cursor a little bit, this gray zone here is the heart, and the treatment on the left is giving a lot more dose to the heart, for example, than the treatment on the right. And this area here is the vertebrae, the spine, and this is the spinal cord in the center. You can see again that the treatment on the left is giving a lot more dose to the spinal cord than the one on the right. So we're getting definitely a lot fancier, a lot tighter in what we can do with radiation. One technique I'm going to talk more about tonight is called stereotactic body radiation therapy. And this is a technique which has really been around for the better part of 10 or 15 years, but it's really coming into its own in the last maybe 5 to 8 years. There's a lot more data behind it. And what it is it creates a much better immobilization. So we're keeping the patient in a very still position, and we're accounting for movement of the lungs or movement of liver, whatever we're going after. And we're using imaging like the cone beam CT I was showing you before, and getting down to this very accurate treatment. And so what we've done is taken treatments that typically go on for weeks at a time and condense them into only 1 to 5 treatments. And these are very high powered, very focused, and have allowed us to go more aggressively after a lot of tumors that we really couldn't before. So I'm going to touch, radiation therapy in the setting of lung cancer is used for early stage, that's non-small cell lung cancer, locally advanced, things like stage 3 where it's spread into lymph nodes. It's also good for limited stage small cell lung cancer, and extensive stage where it's spread a little bit more. But we don't have time for all those. So I'm going to talk about the early stage non-small cell and oligometastatic. Oligometastatic is when the cancer is spread beyond the chest in this case, but only to a limited number of sites. And this slide is a little on the busy side, but I'll give you the takeaway, which is that we had been using for early stage, so stage 1 lung cancer, non-small cell. You got a tumor like this one, you can see in this picture here, this nice rounded tumor. And if the patient was not a surgical candidate, we were treating them with about 6 to 7 weeks of daily radiation. And the success rate in terms of local control is only about 50 or 60%. And that's all we really had to offer for years and years. And then we developed these stereotactic or these SBRT type of techniques I was mentioning. And they studied it in this famous RTOG0236 study. And they saw that the local control rate shot way up. I talked about 97.6% at 3 years. And that percent control did drift down over time, but much, much higher. So we knew that we were really on something there, and started to look at how aggressively we. The trial was done again with patients who either were medically unfit for surgery or had refused surgery and had tumors that were relatively small. So it was a really high-powered, good local control and very acceptable toxicity. They ultimately more formally compared this SBRT to conventional radiations. We already kind of knew compared to historical data that this was better, but they ran it to see, and they showed that yes, indeed, the control rate was much better when it was studied more formally. In this case, it was 14% versus 31%, but big picture was stereotactic. When we can use it, gives a much higher dose, much more concentrated than possible. Try to do that. There have been some efforts. People wonder, well, what about surgery versus radiation? And the only way to really answer that properly is with randomized trials where people enroll and the computer flips a coin effectively, and you get surgery, you get radiation. And those trials have been really hard to accrue patients to. And ultimately, they did take 2 trials that had only partially accrued and put them together and published the results. And in that trial, actually, it made radiation look slightly better than surgery, but I don't think people fully believe those results because it just wasn't high enough numbers. And really for patients who are still medically fit, our top choice is still surgery. But see, radiation is not far behind, and definitely for patients who are in decline or medically unfit, then we know the radiation is a great option. Let's look at oligometastatic. There were actually 2 really exciting papers for us that were published in 2019. The first is referred to as the Sabre Comet study, and what it is, it took patients where the primary tumor, the tumor in the lung, had been controlled, and they had anywhere from 1 to 5 metastatic sites. Could be in the bone or liver, could have been in another part of the lung, and they randomized, either you got that stereotactic treatment, this SBRT, to all the sites, or just your standard of care kind of palliative treatment. And a huge difference was seen. The median survival went up from 28 months to 41 months just from doing that. So that was a big win for us, and understanding that going more aggressively after these metastatic sites makes sense, versus before the idea is we would only do that if they were causing pain or bleeding or something where we're playing defense. Now we say, well, we can play a little offense here and try to get rid of these spots. The other study that was published in a different journal, another great journal in 2019, same scenario. This is non-small cell lung cancer, to be clear, and these patients had 3 or fewer metastases. But same idea, where there's no real progression at the site in the lung for at least 3 months after doing either chemotherapy or some of those targeted therapies Dr. Chiang was mentioning. And they were offered either what they call local consolidative treatment, which is either that SBRT or surgery, and for the most part in the trial was the SBRT, or maintenance therapy, so observation. And again, a big difference in the median overall survival, 17 months to 41.2 months. So we've seen really just in the last couple of years that we have the technique for stereotactic. We see how to safely use it, and when to hold back, when should it be surgery, when should it be radiation, when we're going to do a combination. There's some patients where one of their lesions is a great target for surgery, but another one really isn't, and so they get surgery for one and stereotactic for another, for example. And so we just have a better idea of how to apply this, especially in these unique settings where cancer has spread, but not very extensively. And so that's been very exciting for us. In terms of some future directions and how Yale's getting involved, one of my colleagues, Dr. Henry Park, has opened a trial where we've had a little difficulty with radiation with tumors that are called central tumors, meaning ones that are right up against the main airway, some of the big vessels, and we know that we have to be a little more careful in the dose there, and those have typically been done with 5 treatments. And he started a trial to see about being able to safely and effectively treat that in 3 treatments, and that was started in New Haven, but we've opened it up in multiple care centers at this point. And the other one is a trial where they're taking SBRT, and then it's with or without adding some immune therapy afterwards. And there are actually a few that are going on, but this Keynote 867 has a lot of excitement. I believe it's either has opened or is about to open at Yale, and so we're very excited about that as well. And just a brief word, in Connecticut and some of the surrounding states, there tends to be a lot of advertising about certain machines, especially the CyberKnife machine, you can see on the bottom right, and sometimes about protons. And I'll just talk about this briefly. The CyberKnife machine, if you look carefully, it's really the robot that is used, not the robot like Dr. Blasberg was talking about, but the robot they use for building cars on the assembly line. Is the base of that machine, and the top of it is a miniaturized version of that linear accelerator, and it delivers little pencil beams to tumors, and it's a very good machine for doing stereotactic treatments. It doesn't have the flexibility to do other larger, more traditional treatments like the TrueBeam does, so it's a little bit pigeonholed in what it does, but it is excellent at what it does. And the problem really for those who use it is that there's no particular reason to travel for that machine when you have other machines that can do just as good a job and are much closer to home. So it was something that was quite exciting some years ago. Now, I'd say a little less exciting because other machines can do just as well. But you do hear about it on the radio a lot for lung and even more for prostate. And the other side is they're on the protons. Protons is spitting out a totally different particle, an actual proton particle instead of an X-ray. And tremendous advertising. They're very, very expensive machines to build. Yale is looking into whether we might want to be involved in having one of those ourselves or collaborating with someone. And it does seem to have clear advantages in certain tumors and other tumors not at all. Lung cancer is one of those ones where it's much less certain whether there's an advantage to it. So we need some trials to see if it's better or actually worse potentially. There have been some studies that have shown things like the trial for breast cancer, for example, it showed a little bit higher risk of rib fracture using protons instead of regular X-rays. So protons are something that are really starting to get more popular in the country, and there's starting to be more machines, but the vast majority of the treatments being done in the US are being done with traditional linear accelerators that have been refined, like the TrueBeam I'm showing on the top there. And so that's it for me. Be happy to take questions as well.
Thank you very much. That was wonderful. Let's see what questions we have. Here's a couple. Use IMRT to treat a tumor that has become resistant to immunotherapy in the hopes of reducing or eliminating it, even though you're in the late stage.
That's a great question. So yeah, so that's been one of the, and that ties into the spirit of those two articles that I was mentioning. You know, the one of the paradigms in medical oncology from before, I think, had been, you know, if there are one or two spots that weren't responding and the other ones were, that maybe it's time to change the drugs entirely. And now that we have better, more, you know, focal treatments like SBRT, we know that that may not be the best way to go about. Maybe since you're controlling, let's say, 8, treat the 2 that are acting up, and which may have a slightly different mutation or something that's going on with them, and level the playing field again. And so that has been very successful, and we're seeing a lot more of that in the last few years. You know, there is some interest as to whether immune therapy and radiation play particularly well together, because there's a thought that radiation therapy is breaking up the tumors and exposing more of the pieces, if you will, to the immune system, and therefore helping to supercharge what the immune system can do. It's unclear when that happens or to what degree, and so that's why some of the trials like that Keynote trial I was talking about are of great interest. We've seen even some cases where we've treated 1 or 2 spots, and additional spots that we did not treat got better, and they call that the abscopal effect. And it's another one that we're only beginning to understand. Certainly it doesn't happen all the time, but there's something special that happens sometimes between radiation and the immune system.
So radiation is somehow activating the immune system, you know, so you see effects at other sites even where you did not radiate.
Yeah, and we've seen that. We've seen that in lung cancer for sure. We've seen that a nice trial result in prostate cancer recently, and I think we'll see more of it. It's as we're seeing it, but we haven't fully realized how to harness that potential, or you know, when it's going to happen versus not. So that's where some of the trials are coming in.
Here's an interesting question about the knives. What's the difference between cyber knife and gamma knife?
That's a good question. So both were designed by marketing geniuses who are good with names and words. And the cyber knife, so it's surely that machine against that miniaturized robot on top of or miniaturized linear accelerator on top of a robot. And that machine is for stereotactic treatment only. It can treat in the brain, the neck, the body, really anywhere in the body it can technically get to because of the mechanical arm there. The gamma knife machine, let me go. Cyber knife is also, it's fundamentally shooting out X-rays. The gamma knife machine is looks like a half dome, really, and it's for treatments in the head only. It's usually for brain metastases. And a helmet is bolted to the head, and the patient is put into the dome. And in the dome, there's a constellation of radioactive pieces of cobalt that all shine down into one spot. So you move the head around so that spot is overlying the tumor, and you kill the tumor that way with radiation. But because of that dome effect in the constellation, there's only so far you can put someone into the dome, and so it's really only practical for the head. It's one of the earliest and best of the radiosurgery machines for brain metastases. And so you see certain programs like Yale's has a very robust brain metastasis program where you'll have a dedicated team that just does tons of treatment very, very well with that machine. That's all they do on the machine. So Dr. Veronica Chiang is the neurosurgeon, for example, in charge of that, and she works with our radiation doctors to do those treatments. So that's how that's handled in New Haven. At some of the satellites, like at Greenwich Hospital, we actually use the linear accelerator to treat brain metastases. But anyway, that's the difference between CyberKnife and
Very helpful. Maybe one more question. Proton therapy, is it more effective than some of the showed? And where's the nearest proton therapy?
So as far as we know in lung cancer, it is not more effective. The first question we ask in terms of effectiveness really comes down to dose. Is this something where we can put more dose into an area? And for most cancers we can think of, that's not the case. We're not putting more dose in with X-rays than with protons, or protons than X-rays. We're really referring to the same set of data and trials that have established the proper doses. There are some very, very limited exceptions, but not many. The hope and the dreams of around protons really has to do with the side effects, because under optimal circumstances, a proton a proton beam goes into the body, it suddenly deposits its dose at a certain point and then stops. Versus an X-ray goes into the body, deposits some dose, but then pops out the other side, so you have like a track of dose. And so protons for, let's say, treating a child's spine, to me, are clearly better, because you can take one beam from the back and treat it, and you're not treating any of the abdominal organs, so that's fine. But if you're treating, prostate, lung, most breast treatments, most things in the head, you just don't have that same advantage. You end up needing multiple beams. You're still going through things. So the protons aren't magic. They're just very helpful in certain situations. And what happens, because they are, in part because they're so expensive to develop and run and build, then the number of proton units in the country for many, many years was really small. You're talking about really 2 or 3 units in the entire country, and not many outside the US. And it's really just in the last maybe 5 to 10 years that with collaborations between academic centers, or sometimes between academic centers or private centers and venture capital groups, you're seeing more of these pop up. And so we're just beginning to run some trials to really be able to figure out more academically, more scientifically, which is better and when. And so the nearest proton centers to us, you're talking about Boston, New Jersey, and recently one opened up in the East Harlem area. It's a collaboration site between some centers, and Yale is in some talks about whether to develop their own and participate in the research and everything that goes along with it. But for most people, now that we see, I tell you, there's not many occasions where you really need or should travel for protons, but certainly a very interesting machine, and is going to have its advantages in some situations.
Right. I hear rumors we're going to have one soon, but at least in lung cancer, sounds like we have state-of-the-art equipment that is what's needed at this time.
Yeah, and protons have some particular challenges in lung cancer, because they're a little bit fussy about what tissue they're going through and moving tissue and accounting for that. So I think there's excitement about everything, but not as much about lung cancer at this time. So Yale definitely has all the state-of-the-art radiation machines for lung cancer.
It really is incredible, and so are all of you. As it's been a great panel tonight. I really appreciate everyone who's joined. I want to make a few announcements that this will be posted. The recording will be posted on yalecancercenter.org. So you can go and you can hear this again. And if you have additional questions, you can reach out to canceranswers@yale.edu at any time. So that's canceranswers@yale.edu. Bruce, Vinny, Justin, Anne, I thank Renee Godet, who's our coordinator for these programs. Thank you very much. We're exactly on time. And it's my pleasure to now close the evening. Thank everyone who was online. Please reach out to us with any questions. I know I've learned a lot tonight. It's been a great evening. Have a good night. Be safe, everyone.
Thank you, everybody. Thanks for coming.
Everyone, thanks for joining.